Yeah, again, thanks for allowing me to be here. Um, some of the background is going to be, I think, pretty basic for you. And if you know anything about the psychology of chronic pain and treatments that are psychological and how well they work, you'll know that cognitive behavioral therapy or psychotherapy in general is pretty good. Has pretty good results for chronic pain. We've been at it in the development of psychological models and methods for many years, as you'll see in a minute. And I think we have a pretty solid record of success, with one small caveat, which is I wouldn't say that we're getting better and better every day. We seem to be possibly a little bit stuck and maybe need to crank it up a little bit and find some clever new ideas. There are some methods that we use that maybe are not ideal for answering the kind of questions that we need to answer these days. And for one matter, we, like most researchers in psychology, use a lot of aggregated group data, look at means and mean effect sizes and mediation, and we use regression models and prediction models. So we use a lot of, many people mashed together into a group to sort of investigate relations between variables, either correlation or causal. And we're tending to look at what kind of treatment do you need for the kind of conditions that we know that people have out there? Like when people have low back pain, which treatment should they should they have? What we are I'm going to argue relatively neglecting is to think about the individual more often, to focus deeply on mechanism, not just in a kind of an implicit way, but in a very detailed way, in a very high precision way. And in actual clinical practice, our delivery has a bit of personalization in practice, but probably it's not highly personal as it could be. So, we have made some progress over time since the 1960s. We definitely don't use the same methods. We don't have the same variable names. We don't have the same sort of basic approaches. We Things do move ahead. Are our effect sizes getting bigger and bigger? Probably not. This sort of last blue phase that you're looking at here is that's where I think we are now, 2025 and beyond. And I think the kind of the new stuff that's appearing in this piece of the timeline is what I'm going to talk about today. And what I'm going to talk about really in many ways all feeds back to what this fellow said or asked, the question he posed many years ago, before most of you were born, I'm afraid. And he said, and this is called the Gordon Paul question because that's what that guy's name is. He said, what treatment by whom is most effective for this individual with that specific problem under which circumstances, and how does that come about? If you're a treatment provider in chronic pain management, this is the kind of question you need answers for when you sit down with your next patient. I would argue whether you're a psychologist, an anesthetist, a neurologist, a rheumatologist, a psychologist, or someone else, I think the question is rather similar. What does this person need, and um, who should deliver it, and how does it work and under these circumstances? Sadly, certainly in psychology, and I think it's fair enough for me to talk about how have we done in psychology. We have not yet answered this question very well. Our answers are not very good so far. We have tended to try to, if you were an alien and you landed on Earth and you observed what pain researchers and clinical psychologists and interdisciplinary teams are doing, while they try to figure out how to produce better treatments for people, you would probably decide that what people are doing is they keep making new therapies. And they keep making new therapies as a hope that if they do this, they'll find the one that's the best or the best for what you have. And we have been rather good at this. We keep making and making and making. Begins to sound like Dr. Seuss, by the way. And have has this process, this sort of the invention of one new therapy after another, actually represented a way to make progress? Probably not, I would say. And probably because this kind of level of analysis is too coarse. There's too much variability of response within each one of these treatments and not that much between them. And after all, psychological treatment is not like a medication that you manufacture in a factory, and you need to manufacture it to certain set specifications and then just find which medication you need. This kind of this we need a higher grained analysis, more detail. So really, this is where process-based therapy kind of comes in. They say we need an alternative. Rather than think about people as the one diagnosis and coming up with the treatment that's been demonstrated for that diagnosis, we need to do it differently. They've also dug up this old Gordon Paul question from the 1960s, and they've slightly restated it. And they say, in their terms, the question is what core biopsychosocial processes should be targeted with this client given this goal in this situation, and how can they most efficiently and effectively be changed? And in a nutshell, that is process-based therapy. To say it maybe in some different words that help clarify, you could say, these are particular words, so yeah, be patient. Process-based therapy is a contextually specific use of evidence-based procedures linked to evidence-based processes linked to evidence-based procedures to solve the problems and promote the prosperity of particular people. Obviously, they wanted to get a little P thing going on there at the end. But if you see what this says is process-based therapy needs two ingredients. It needs evidence-based mechanism, okay? And it needs evidence-based methods that push those mechanisms. Essentially, that's sort of the whole ball. And in terms of what are these processes, they further define them for us. And this is all in the abstract, and we can later talk about some examples. But processes of change in this model, in this therapy approach, are theory-based, dynamic, progressive, contextually bound, modifiable, multi-level changes or mechanisms that occur in a predictable, empirically established sequence oriented toward desirable outcomes. Now, you will have to read this a few different times and sit with it before you know exactly what they mean by saying all these things. I can sort of assure you that this is actually, although it's complicated and it sounds overcomplicated, it is a rather good definition of what we're talking about. In simple terms, it is what the method moves. You deliver a method, behavioral activation, exposure therapy, goal setting. It moves some kind of psychological process of change in an incremented, step-by-step, progressive fashion. As you drive it, it drives outcome, okay? And some of these other modifiers in here, these adjectives, simply make it even more clear. I'm not going to define all these terms, it's too much. We've tended to sort of diagram it or kind of imagine it this way. It is that people come in with their unique set of problems. If we analyze their unique set of problems, we will find in those problems interactions between potential processes of change and symptom sets and behavior patterns. And in this kind of network of events, in one way or another, we will analyze it. We may analyze it informally. We'll find what we think are the central features where if you move the process that you define as central, it'll move outcome. So you have a process selected, pick a method that you know moves it, deliver the method, assess whether the process is moved, maybe assess outcome, see where you are, reanalyze your data, your sort of network of all of these elements, and then retarget a new method based on your new analysis. Keep doing this until you reach sort of the outcomes that the person wants. 2018 was the first book on process-based therapy. It would have only been 2017 or so that there were sort of first articles that really talked about this in this sort of new way that's being presented. All right. By 2021, we had a book that says this is how to do it. All right. The point of my talk today, which I could have reminded you of in the beginning, is where are we at so far in pain research in relation to this approach? Many articles have come out. I think a nice potential outcome of this approach that's being promised is that it could lead to integration. Maybe one day we don't have to have so many different brands of therapy, so many types of therapy. We don't need to have DBT, behavior therapy, CBT, MBCT, emotion-focused therapy, and on and on. Maybe we can just look inside these therapies, find their empirically supported mechanisms, and basically put these in a library of mechanisms and then deliver treatment and pull from the mechanisms we need. So I almost thought it would have been really persuasive to show you just how many papers have come out about process-based therapy, really promoting this as the next best thing. Along with this, I think a lot of promotion of the sort of the goodness and the arguments for process-based therapy. There's new ways to think about organizing therapeutic processes. This is where I can make a touch between this EAM model. EAM stands for Extended Evolutionary Meta Model. This is a way to think about whatever therapy approach they're coming from. You have mechanisms supported inside in your evidence. Pull those out. Which domain do they fit in? There's 6 psychological process domains here: self, cognition, affect or emotion, attention, motivation, overt behavior. We also have biomedical, biophysiological, and relationship cultural dimensions as well. Any of these dimensions can be dimensions where we sort of situate our processes of change. Psychological flexibility, by the way, intersects exactly with these 6 dimensions of psychological level change, just to mention that. And what comes with process-based therapy is an entirely new way to think about the kinds of problems that clients or patients have, not as what's your diagnosis? Is it fibromyalgia? Is it low back pain? Is it nociplastic pain or something else? But what are the elements of your problem as you experience them in terms of behavior and modifiable process? And we get network diagrams that are either perceived causal networks or empirically derived, temporal, empirical networks of variables. This approach of process-based therapy is being touted as sort of, the next step in clinical psychology. Researchers in pain management are also in on this and saying, yes, we should do this for chronic pain. It should be how we focus our research and treatment development from this point going forward. When very smart senior clinical psychologists get together and they talk about what do we need to do to make the field better. This is the Marburg Declaration. You might have heard of that place. You may have read this in Clinical Psychology Review. This is not a process-based therapy group. It's a general group of experts. But even from them, we see the same kind of themes emerge: idiographic, person-centered, individualized, personalized, mechanism-focused as where we need to go. I'm trying to give you here a sense of just how many papers have come out. So naturally, I do what our students do these days. I asked Grok and I asked our other AI agents around here, how many articles are out there on process-based therapy, and They tell me based on a search in PubMed that it's 50 to 100. I think it's probably closer to 100. They kind of break up this way. Prior to around the 2018, 2019 stage, there was certainly less than five. The next 2 to 3 years, 10 to 15 papers came out. And then beginning in 2022 and beyond, we're really sort of hitting our stride. And I think we are reaching 100. I'm not sure this is the extent to which I've tried to sort of pin down how much has come out. So I think we all know this. If you're in pain management, obviously you go to work every day with a lot of questions. You look at what we're doing and you look at our progress. And if you're like me, you think, well, at least in clinical research and applied research and treatment development, I think we know we need to do something different because I think we've been slogging away with the same kind of methods probably for too long and the same kind of variables. Spent too much time probably on catastrophizing and self-efficacy and maybe too much time on static set sort of treatments set up in a set static sequence without the elements being delivered guided by some kind of analysis of mechanism. You know it because when you look at, if you work in a clinic and you have occasion to see the data from your clinic, you know that sort of change scores look fine. On average, they look quite good. Here's some depression data from a service that I used to work at in London. And the mean is totally fine. What is not fine in some ways is that we do not account for, we do not understand, nor consider carefully the people who don't get average change, who get worse in some cases. Nor do we, I think, understand the cases who change and improve remarkably well. It's not just depression. We see the same thing with every outcome variable. Everything, all our outcome variables represent change scores on a distribution. If we map these people like sort of like spaghetti from the beginning of treatment to the immediate post-treatment and then to the follow-up phase, lovely what you can see and what you think about if you think about every person in your 276 person data and what happens to them individually. What if we could account for that? Wouldn't that tell us something new? The black line there is the average, but the deviations around the average are, yeah, they're substantial and super interesting. Um, Here's a couple of our PhD students. I almost hope you've seen this before because this was definitely a labor of love for our group. We were so pleased with this paper when it finally came out. It wasn't an easy job. But I think it's definitely pertinent to what we're talking about and pertinent to the arguments being made here, which is we need to focus on individuals more. We need to understand mechanism in individuals more. Then we need to use these data, this information, this knowledge to develop, test, and refine more personalized treatment. All right. So you see the title of what they did here. It's Are people with chronic pain more diverse than we think? An investigation of ergodicity. Ergodicity is this assumption we make whenever we take group data, we analyze the results, we get a summary, and then we believe or suppose that it will apply to the individual people in the group data. Data, in order for data to do that, they must be ergodic, and it turns out psychological data probably are not ergodic. This demonstration here in pain variables basically shows that that is indeed the case. There is a mismatch. This is the argument in pictures. In the kind of if you can see my cursor in the sort of the upper left corner, you see this scatter plot. This is basically a scatter plot of psychological inflexibility and interference. I mean, this is what sits behind what we are doing when we find a correlation, right? So, relations between two variables in group data is like, this is our lifeblood. This is what we do. This is how we find what's related to what. And so here's a scatter plot in group data. There's nothing particularly troubling about this until you take some of the individual people within the scatter plot and then you take their individual data. You have some data on the lower panel on the left side. This is that little green dot, and this is their if you took their data for 80 days twice a day, 40 days for twice a day, sorry, and you got the same correlation between BPI interference and psychological inflexibility. Yeah, that looks all right. That scatter plot looks reasonably similar to the group scatter plot, so you can feel assured. The group data estimates relationships that are just like the individual people. But if you pick a couple other people, like this other red person, and you take their individual data, so how does interference and psychological inflexibility correlate for them? You get quite a different story. It's practically a zero correlation. It's slightly negative. And then finally, if you took yet another person, we could do this all day. Take all the people, give us their individual relations between these variables built on data collected from them in time. Okay, because when we get group data, we think that's the individual people's data in time. As their inflexibility goes up and down, so will their inflexibility to the extent reflected in the correlation. But what you see in reality is all the individual people are quite different. The individual data looks something like this. This is actually a real participant's data. Okay, so we need to understand what's going on in here. And what we're learning so far is that group data do not model this very well. If we took 80 people and we took those 80 people and we got their individual data, their relations between depression, psychological inflexibility, interference, and catastrophizing, whatever we're interested in. And then we took every single sort of observation across the 80 people, and we took those 80 observations as a cross-sectional study. We have 80 cross-sectional studies, and we have 80 studies of single people. If we take the correlations that you get from those within person versus between person analyses, you get a blue frequency distribution and you get a green frequency distribution. The green one is very comforting and nice. These are the group data. The group data look pretty tight. The group data give you an average correlation between variables between, I can't see the top here. Well, between psychological inflexibility and depression on the one hand here, catastrophizing and pain interference, and so on. You get the group correlations look nice and tight and positive. The individual people, their correlations of the same variables look really substantially more variable all over the place. Maybe this is easier if we look at it as a table. If you're not into graphs, we can take mean within person correlations and mean between person correlations. They're not terribly different. The between persons gives us a much sort of more inflated sense of relationship than the within person individual people correlations on average. What's sort of dramatic, however, is look at the range for the individual people. It goes from, less than zero all the way up to about as high as you can get. So people are all the way across the board in the magnitude of their correlations. Of course, you'd have to move that box over so you can see the range in the between persons. But yeah, the between person ones are the kind that we're more used to seeing, but the ranges are totally off. They're not the same at all. That's one problem. All right. The other problem is that, I think we've recognized for years that we need to understand mechanism, because understanding mechanism can be a way to help us refine our focus within the methods that we use in treatments. So we have a theoretically based treatment. It has methods that the theory says should drive what the theory says are the mechanisms of change or the mediators. And for years, we've used this kind of standard Barron and Kenny type approach, as if this is really going to tell us, kind of the mechanism of the treatment, and that in turn will help us to build better treatments. Well, this article I just showed you the title page a second ago. In this article, they say, no, probably not. The more we look at this, the more we think that sort of these conventional approaches to mediation aren't really going to give us what most of us think that we need these days, which is a deeper understanding of mechanism. And that is because they're falsely assuming that mechanisms are linear, that kind of go up in a steady, kind of one direction fashion, that they don't go back and forth, that they're univariate or paucivariate, weird word, but only a small number of variables are needed. And we think that they obey assumptions that need to be obeyed so that we can take nomothetic results and apply them to individual people, which I've just showed you, at least in our one example study, we can't assume that. I think any therapist, if you have them think about this for just a few minutes, they will tell you that treatment mechanism or process of change is dynamic, multivariate, and bidirectional, and it's going to be very individual. Where we have data on this, we know it's true. It's not just reduced catastrophizing, decreased avoidance for everyone. It's for some, yes. And it's not just in a steady sort of linear relationship from beginning to end, a little bit more activity every day. It's up and down, back and forth. Outcome changes, move process changes, move other process. So it's rather complicated and sort of dynamic and interesting, I'd say. But true to life, Barron and Kenny's triangle probably doesn't cut it. On the positive side, I always like to include the positive side here when we've just ended this sort of litany of the sort of the problems we need to contend with. Where there are personalized treatments, okay, where we do something that is beyond just the set of sequences of methods, everyone gets the same method in the same order. When we personalize, we do get better results. So here's a meta-analysis. It's not huge. It's only 9 RCTs. I can't wait until I can show you an RCT that's bigger than this. This is in mental health. It's not in pain management. Nonetheless, you do get a nice effect size here. In each of these studies, what you see is personalized compared to non-personalized. It's not personalized compared to nothing. It's personalized compared to standard treatment the way we do it today. And on top of standard treatment, you get an effect size of 0.22. Not bad. Status update. I said status update. I could have told you in the beginning the status update is going to be pretty meager and the talk is mostly going to be introductory getting there. We've done the introductory. Here's the status update. I don't have a lot to tell you. Treatment continues to be, there's a trickle of kind of personalized, studies about personalized. Studies about personalized in pain management typically mean measure some things, take some data at baseline, give people a series of components based on what you learned about baseline. True. Different people get different series of components, but the components are like preset at baseline based on some assumptions. Here's one example. Perfectly fine study, nothing wrong with it. You'll know some of the investigators. Not a huge study. This study itself is basically really a study of if we look at registrations of what people access and what they say they access, do they match? But I'm using it here merely as a demonstration of what do we normally do when we personalize? And this is what we do. We have a bunch of modules sort of standard in the background. We assess the kind of methods that people don't use, and then we give them what they don't use. And we call it personalized plan, but it isn't dynamic. It's not mechanism based, I'm afraid. It's sort of module or method based. And does it work? Not really what I'm going to talk about today. It's fine as far as we know. There's at least a half a dozen, 8 or 10 studies like this. What we're missing is that study of tailored, customized, personalized versus not. Even in this kind of territory of the, you know, kind of set the sequence in a personalized fashion at baseline. We're still waiting for a very good comparison of tailored versus untailored. We're not there. It certainly isn't process-based, so it's not a great bit of progress for our agenda. I did the study with some folks from Barcelona. It's a neat study. It's not fully process-based, but it is proof of concept of process-based. This is a method that I recommend any clinical researchers do if you can. If you're going to do an RCT, get some intensive longitudinal data as well. So this is a three-arm behavioral activation versus ACT versus treatment as usual comparison, low back pain plus depression. What I show you here, the whole trial it's been a lovely project. We've had several studies. This study here is just to show you one thing. This study shows you in the three arms, ACT, behavioral activation, treatment as usual, for depression and pain intensity as outcomes. What kind of relations are we finding between changes in depression and the process of change issues? So if you can, again, where's my cursor? Again, if you can see my cursor, I don't know, I hope you can. You can see these kind of betas. So these are kind of basically coefficients that show the magnitude, the size of the relation between activity level process as a process of behavioral activation, and these other processes, experiential avoidance, lack of contact with the present, self as content, fusion. These are inflexibility processes. So you can see them. How do they match up in their relations with improved depression or improved pain intensity? And the point is, these data are being treated here like we treat data in meta-analysis, and we can look at the heterogeneity here. So this is the heterogeneity within the ACT arm. So what's the differences in the magnitude of relations between process and outcome? Huge, huge, mainly, huge, mainly, not everywhere. So the point here is look at how people are different in the processes that drive the magnitude of the processes and which processes drive improvement, proof of concept. This study was very, very promising until I got past the title and abstract. This says process-based, single session process-based cognitive behavioral intervention. Lovely. It's pain. It's great. It's 31 people, not brilliant, not huge. Unfortunately, it is process-based in the sense that there are processes that are being impacted on the methods delivered. It's not process-based in the sense that they're not collecting individual data or analyzing individual people, then customizing or personalizing treatment accordingly. Everyone gets the same sequence of treatment components. It's one session, very interesting, great for them. Four components, as you see: education about avoidance, acceptance, mindfulness, acceptance methods, cognitive diffusion, blah, blah, blah. It's a single arm. So these are uncontrolled effect sizes. Yeah, quite impressive for a single tiny one session treatment. So really interesting, something going on here. It's in patients. There are other treatments going on at the same time. I don't see how they can isolate which components, their treatment or the wider treatments in the unit, which ones are responsible for outcome. But yeah. So there's the processes there. They change, lovely. Outcomes, they change as well. So finally, the status update is we've done a study. It's under review. I'm not going to tell you a lot about it and spoil the surprise, except the very tiny, ray of hope. So this is a single case, randomized case series, multiple baseline design. And done by my PhD students, led by Amani Leverfjord. And I'll just tell you what they've done here, and that is they're assessing some people and finding, in terms of their perceptions of processes that drive their outcomes, what's the most central process for them and what's the least central process for them. We've then intervened in a randomized and controlled fashion, both the least central node and the most central process node, and it looks like in the data so far, if you intervene with the most central node, you get the greatest impact. That's the sort of bottom line. You have to read the paper when it comes out. It's not sort of out yet. The final is the protocol. No data here. They're on the right path. You may know these people. They're great. They do some really cool stuff. I think they're onto something. But yeah, again, not a lot of result there. That, my friends, is the whole cup of tea. Summary. CBT is what it is. If you know about it, you know it's good, you know it's accepted. It's luckily pretty widely available in many countries and medical centers, and it's fine. The average person does okay. What we don't know is why, and we don't know much about mechanism. We think now, whether you come from the specifically a PBT camp or you're in sort of in the general field of clinical psychology, you know we have been saying it. I think it's believable. We need to be precision, personalized, process-based. We need to dig into mechanism in a serious way, differently than what we've done before. We can't just do the Baron and Kenny triangle anymore. We need more complex ways of thinking about process. Quite amazingly, I did when I assigned myself this topic, I really did think there was going to be a lot to share with you. I'm as amazed as you are that we've not moved past the proof of concept stage with process-based therapy. I thought, the first book having come out in 2018, here we are 7 years later, someone would have crossed the finish line. It is not the case. We're still waiting. And if you ever want to come visit us, that's what it'll look like. Thank you so much for your attention.